Good morning, everyone. I see that it is 8 a.m. and thanks to all of you for being here this morning. And for those of you who don't know me, my name is Jackie Cruiser. I'm an assistant professor in allergy, pulmonary, and critical care. And I have the honor and the privilege of kicking us off this morning for our Department of Medicine Grand Rounds, and really the true pleasure to introduce our Grand Round speaker today, Dr. Sue-Ann Bell. Dr. Bell is joining us from the University of Michigan School of Nursing, where she's an associate professor with tenure in the Department of Systems, Populations, and Leadership. Dr. Bell received her Bachelor of Science degree from Florida State University, followed by a master's in nursing at Emory. She then received a second master's degree in health and healthcare research and her PhD from the University of Michigan. That is where she is a nurse scientist and a family nurse practitioner who leads an extramurally funded health services research program that broadly focuses on how climate change and climate disasters affect human health, particularly among those communities and populations that are most vulnerable, including older adults. The impact of her work is evidenced by numerous speaking engagements across the country and also by her service on multiple federal advisory councils. She's an appointed member on several committees of the National Academy of Sciences, Engineering, and Medicine. And in fact, she's actually presenting to us today from Azerbaijan, where she's attending the United Nations Climate Change Conference. So her obvious expertise on this topic is also underscored by her clinical activities in disaster response. She's a member of the U.S. Department of Health and Human Services National Disaster Medical System, and she's had over a dozen deployments, including with COVID-19 response, Hurricane Irma, Hurricane Maria, and the Western U.S. wildfires. So on a personal note, I've had the absolute privilege of getting to know Dr. Bell and her exceptional scholarship through a health services research group over the past several years. So it really is an understatement to say that I'm thrilled that she'll be sharing her work with us today in a talk that's aptly titled "A Health Policy Hurricane: The Climate Crisis and Health Services Research." So thank you very much, Dr. Bell, for being with us today.
Thank you so much. I really appreciate that very generous introduction. I'm very happy to be here. As Jackie said, I'm presenting from Azerbaijan, where it is 6 p.m. Definitely the jet lag is feeling real right now. But thank you so much for having me. Let me start with disclosures. I have no disclosures, I am a NIH climate change and health scholar this year, and I need to say that this talk today is my opinions and do not necessarily represent that of NIH or NIA or the NIH Climate Change and Health Initiative. So a little bit about our roadmap for today. This talk is organized into 3 parts, and we'll start by talking about the impact of extreme weather events on health with a focus on older adults. And then I'll talk about some current research, a lot of my own, focusing on the effects of extreme weather and health outcomes. And then finally, at the end of the talk, we'll talk some about some urgent policy and research needs that can better promote healthy aging in the face of extreme weather events, especially around mitigation, preparedness, response, and recovery. So just to introduce myself and my work, as Dr. Cruiser mentioned, I define myself as a clinician scientist. My work is really informed by my disaster deployments with the National Disaster Medical System. And as you can see on the picture on my left is the blue arrow is taking off on a C-17 on our way to Hurricane Irma response, where we landed by night vision after the Orlando airport had already closed because of the hurricane. The picture on my right is supporting the U.S. Navy ship the Comfort after Hurricane Maria. So on a day-to-day basis, though, my daily life is actually sitting at my desk, looking at data, writing papers, supervising students, and building my program of research, which focuses on the health effects of disasters on older adults. And my work is informed by the World Health Organization's operational framework for building climate resilient health systems. You can see the spokes on this wheel. I situate my work at the intersection of emergency preparedness and management and health and climate research. But as was mentioned, I'm presenting today from Baku, Azerbaijan, where I'm here for 2 weeks for the United Nations Conference on Climate Change. And this is quite a big event. Around 70,000 participants were registered. And they've actually transformed a large stadium into a conference venue where when you're inside the stadium, you don't actually even know you're in a stadium. It feels like you're in physical rooms. Only the walls and the ceiling are made out of cloth. So definitely an interesting place to be and a very beautiful city. I've had the opportunity while I'm here to sit in on a number of high level, really fascinating briefings. The picture on my left is the briefing with the U.S. Special Envoy for Climate, John Podesta. You might remember that this position was originally held by John Kerry, who stepped down, I believe, about a year ago, and John Podesta is filling that role. He's telling us in this briefing, which was for U.S. citizens only, about some of the changes that we might expect to take place during the upcoming administration. Not really a positive discussion. The picture in the center is AJ Banga, who's the head of the World Bank, and he was speaking at a summit between U.S., China, and Azerbaijan on methane and greenhouse gas emissions. And then the picture on my right is a press briefing from the World Health Organization about the Lancet countdown on climate change. So definitely, I feel like I'm learning so much and really thrilled to be able to be here as an observer, seeing where some of these really important negotiations are taking place. This is also a space for climate justice, and there's any number of organizations here that are talking about the challenges that they face as individuals and communities. And that's also been, a bit more sobering to experience and to interact with people who are really feeling the day-to-day effects of climate change. And one of the outcomes from this meeting, and this was released by Climate Action Tracker just this week. Also, you might have seen this same graphic in the New York Times, where it was published earlier this week. Basically, in this meeting, we're learning what many of us scientists have already been saying for a while, and that is that even with maybe the highest levels of intervention in terms of policy and action, we don't expect to hit the emission goals, and we do expect to see that 1.5 degree goal as not really able to be met. And you can see that the most optimistic scenario, which would require substantial change by globally in terms of emissions, is at 1.9, but the more actual scenario is likely much higher than that. So again, a sobering infographic I'm sharing, and sobering news to be discussed during this meeting. But so when I think about my own work, I think about that I study climate change and health through the lens of extreme weather events. And I wanted to start by sharing the definition of a disaster. This comes from the International Federation of the Red Cross and Red Crescent. So a disaster occurs when a hazard impacts on vulnerable people and populations. So I want to emphasize the red equation in the middle of vulnerability plus a hazard over capacity. That's what a disaster is. So really, when I'm thinking about this equation, and in terms of the research that I do, I am thinking about ways to decrease vulnerability and increase capacity for older adults specifically, and for healthcare and for communities that support older adults. We'll talk a lot about this formula throughout this talk. But I always also like to make the point that disasters are not natural. hazards themselves, like tornadoes or hurricanes, are natural, but the disasters themselves are human-made. And this isn't something I came up with. This, no, there's no such thing as a natural disaster is actually coming from the United Nations Office of Disaster Risk Reduction. So just case in point, if you look at the picture on my left, it's of the flooded Amazon River Basin, which experiences seasonal flooding that is naturally occurring, and many parts of this seasonal flooding support the ecosystem there, as it has for millennia. The picture on my right is of the flooded city of New Orleans after Hurricane Katrina, where this flooding occurred because levees failed that were poorly constructed and older, causing significant flooding, loss of infrastructure, and mortality in the city of New Orleans. And so just point of this picture is to emphasize that, while we use the term natural disaster, it implies that we can't do anything to change these events, when really we can. Another important grounding of my work is that disasters disproportionately affect groups that are already disadvantaged. And in this picture, again from Hurricane Katrina, you can see Nurse Mary Jo D'Amico. She is working to support the evacuation of some of the last patients that were left behind at Memorial Hospital after Hurricane Katrina. And this picture, you might have seen it before. It was popularized in a Pulitzer Prize winning book called 5 Days at Memorial, which is also now a show on Apple TV, which I have not yet watched. But in this picture, the patients that were left behind were some of the obviously last to be evacuated, some of the most vulnerable older adults, people with do not resuscitate orders, people that there were challenges with evacuation. And these individuals, these patients, and also the healthcare providers were at Memorial Hospital for around 5 days without regular communications, resupply, food, water, electricity, and really resulted in enormous tragedy and consequences for the healthcare providers that were involved, and any number of ethical dilemmas that were detailed in the book. But also, disasters are well known to exacerbate economic inequalities as well. And this is a study that I cite often by Junia Howell, who was out of Rice University, that looks at how when disaster costs rise, so do inequalities. So this study looked at disaster-related change in net worth across a number of different racial and ethnic groups, and across education, and between homeowners and renters. And you can see in this figure that among white college-educated homeowners, their change in net worth actually increased after experiencing substantial disaster damage, living in a county that had substantial disaster damage. You can see among college-educated white rentals that rang true as well. High school, not so much, and also lower education as well, not so much. But when we look at Black homeowners and Black renters, we can see that college education still factored into an increase in net worth. But among renters, whether they were college educated or not, had a decrease in net worth. Same for individuals with a high school education or less who were homeowners. And then among Latino homeowners and renters, again, same, college education, home ownership was associated with an increase in net worth, but almost across the board, it was either flat or decreased, kind of emphasizing that that inequalities persist in how people experience disasters. But my work focuses on aging, and we know already that we're an aging nation. The silver tsunami is here, it's on its way. And for the first time in US history, as this infographic from the US Census Bureau shows, that older adults are going to outnumber children in the next decade. And so that calls for greater attention to services that can better promote healthy aging and support older adults. And that's where the center of my work lies. So getting back to that equation of vulnerability plus a hazard over capacity is a disaster. When we're thinking about older adults, there's some challenges that come along with aging for older adults, for many older adults, but not all, that really can affect this, that can serve as a vulnerability. So something that I'm thinking about in the work that I do. We know that around 80% of older adults have at least one or more chronic health conditions. Many older adults live in social isolation. Cognitive impairment becomes a greater challenge with aging, as do frailty and mobility, and then economic challenges or living on a fixed income for older adults. So when I'm thinking about some of these challenges, I turn to a theoretical model or a conceptual model to help guide my work. And so I look at the social ecological model here, which many of you may be familiar with. This model centers the individual and looks at the influences and impacts of different levels across of how that influence the individual's health or different types of trajectories. So whether it's at the interpersonal level, like family, friends, neighbors, the community level, society level, and also policy level. And I overlay that with the disaster management cycle of mitigation, preparedness, response, and recovery. So I'm thinking about, thinking about preparedness, for example, and how can community level preparedness better support an individual? Or how can we develop policy initiatives for long-term recovery that can better support communities and the individuals that live within them? And so this model is the one that guides most of my research, and it's kind of a mental organizing framework for me. Photo break. I get asked quite often, how do you respond with little or no notice to disasters and still maintain a program of research? And my answer to that is that the NIH grant deadlines wait for no one. So in these pictures, I think I'm at, or I know I'm at standing up the first federal mass vaccination center in Oakland, California. And the two pictures on my right, the picture on my left, where you'll see I'm not wearing a mask, is actually at the Princess cruise ship quarantine. And at that time, I was dealing with some of the first COVID-19 patients in the US who are in the first federal quarantine. And CDC guidance at the time was masks only when you're in the hot zone. So in this picture on my left, I'm in our cold zone or our staffing area where we ate and slept, working on an R01. The picture in the middle, I am also working on a grant proposal, finalizing my EndNote library while in a morning briefing in California. And then the picture on the right is one of my favorites. It's I did an hour-and-a-half mock review for a grant proposal while sitting in the front seat of my rental car. And you can see the Oakland Coliseum in the back. I wanted to switch with that segue to talk about recent research around health services focused research around extreme weather events and older adults. This first paper that I wanted to talk about came out probably, I think, around 2018. And we wanted to ask the question, what do hospital admissions look like among older adults after a disaster? Or to answer the question, what is putting older adults in the hospital after a disaster? And so this study used Medicare claims data from the 2011 South Southeast superstorm. I've been asked in the past, why did we choose this particular storm? And so this storm was a series of tornadoes, severe weather that affected several southern states. There were a number of fatalities associated with it, and also any number of tornadoes, I think around 300. So a fairly severe storm, fairly significant impacts. But it was a federally declared disaster, and also one that really didn't get a lot of press. It got a lot of press at the time, but it's not one of those that maybe stays in your memory. So that's important here as we get to the results section. But also the reason why we chose this study is pretty simple. It was an early pilot study. This was the only geographic level data we could get our hands on that we got through a data use agreement. So it was a great first start. And you know, sometimes that's how research goes. You take the data that's available there. It turned out to be important though later. So as I said, we used hospital claims records from Medicare data, and we conducted a self-controlled case series analysis, which is a type of analysis that's often used in adverse reaction studies where you're looking at an immediate defined shock. And so in this case, the disaster itself was the shock. And in this type of analysis, individuals serve as their own controls. And because of that, confounders are controlled for within the modeling. And as I said, the analysis is based on when an event happened. So we looked at two different exposure periods. Exposure period one was the 30 days after the disaster, so a 30-day period. And then we also looked at a 27-day period where we dropped the first 3 days from the study, hypothesizing that those first 3 days of admissions might be you know, trauma or some sort of acute effects from the storm. So we wanted to see if there was a difference there between, you know, the initial effect after the storm and then that, you know, sort of washout period. And what we found was that hospitalizations increased significantly for older adults after this one major disaster. You can see here that 30-day all-cause admissions increased by 4% in this 30-day period. And then in our hypothesized period where we dropped immediate injuries, there was still a 4% increase in all-cause admissions. Then we also found that in Alabama, the state that was most significantly affected or had the most number of tornadoes, severe weather, there was a 9% increase in hospitalizations. So you might ask, like, or you might think, like, oh, I saw the sample size was around 28,000, so 4%, that's not necessarily that huge. And, you know, in health services research, we often have these, you know, fairly small, you know, numbers. But if you think about what this 4% increase actually means when we're thinking about this was one major disaster, which saw a 4% increase. So that actually accounted for hundreds of disasters. But if we think about that, you know, in an average year, there are maybe 50 or 100 federally declared disasters causing these substantial impacts on older adults and the healthcare systems that serve them. That, you know, couple hundred number of increased admissions actually adds up to be something much more important and calls for much more attention to studying this area and developing interventions. So this work led into some work for the National Academy of Medicine as part of a consensus study that I was a committee member on. And this came out, I believe, in 2020, where the goal of this work was to understand mortality and morbidity after large-scale disasters. And this was actually a congressionally mandated report that came about as a result of, you know, very large discrepancies in mortality reporting between federal numbers after federal death reporting after Hurricane Maria, and what research was showing. and also I think what on-the-ground reports were showing as well. So using this study and a number of other studies, this report had a number of recommendations, but I'm highlighting three of them here that I think are important. And that is the need for standardized definitions and methods, that we really need a unified approach to how we're studying and measuring disaster-related mortality and morbidity. We also need a greater focus on indirect impacts of after disasters, particularly around healthcare and infrastructure failure. So if we're thinking about, disruption to healthcare systems, people can't access care, that's leading to adverse outcomes in terms of morbidity and mortality. Definitely some of those indirect impacts are something we need to have a better understanding of. And then finally, this report called for increased data integration, coordination, and collaboration, especially across local, state, and federal entities, to hopefully get to where we can do better real-time decision making about how we're allocating healthcare resources. And so definitely we saw the need for this during the COVID-19 pandemic, and I hope this report helped to inform some of that. But as I mentioned, the first study we looked at all-cause hospital admissions, and then this National Academies work really was trying to look at this in a more fine grain. And so we did another study where we looked at how disasters affect long-term survival among people living with cancer. And so this was a survival analysis study. We used data from the National Cancer Institute's SEER program, Surveillance, Epidemiology, and End Results program, which is arguably one of the best cancer registries out there. And again, we looked at Hurricane Katrina because this was a 10-year, looking 10 years out. So we wanted to look at a fairly large disaster, a true catastrophic disaster that occurred some time ago. In this study, we looked at individuals with certain types of cancer who lived in one of 15 parishes in Louisiana that were affected by Hurricane Katrina. And we compared this group to a matched group of individuals living with the same type of cancer and many of the same types of sociodemographic characteristics. And what we found was that among the group that experienced Hurricane Katrina, we found a 15% increase in mortality among adults with breast and lung cancer, these certain types of cancer, then compared to the unexposed group. So what the takeaway from this study is, it's not necessarily the catastrophic disaster, although it is. It's not necessarily the cancer, although living with cancer, formed the basis of this study. But what our takeaway is that it's the disruption in access to healthcare that was associated with cancer-related mortality. So we already know from the cancer literature that even missing, one session of chemotherapy can be associated with earlier mortality. So among individuals who lived through Hurricane Katrina, had to evacuate, struggled to meet their healthcare needs. That certainly that lack of access to healthcare for this necessary healthcare treatment, certainly as the study showed, was a factor in their mortality. So as we were publishing this study or submitting this study, of course we wanted to publish in JAMA. That's always the goal. This was in the Journal of Internal Medicine. We thought it was a pretty good paper. We didn't understand why it got rejected. Although maybe we did. But right around the time our paper was accepted and in press, this paper came out in JAMA. And so we found that there was someone out there or a team of researchers out there who were essentially studying the same thing we did, only they did it better, got it published earlier. And I highlight this paper because to me, seeing this paper published was really confirmatory to the results that we saw. Although this paper had different analytic methods, different way that they studied survival and people with cancer, they essentially found very similar results. So another big part of the research that I do in studying older adults is studying dementia and dementia care. And Hurricane Helene is still very much in our thoughts and minds. People in North Carolina are very much still in the response phase of, starting to recover from Hurricane Helene. This was in the news about a month ago, almost a month ago exactly. More than 100 nursing home residents, most with dementia, were hoisted onto helicopters, flown around 80 miles outside of the damaged area in North Carolina. And we know from studying dementia care that it's a very important aspect of dementia care to provide routine and familiarity for people who are living with dementia. So the experience of evacuation can be highly disorienting and potentially lead to adverse outcomes. And so this is more recent news, but we published about a year ago a study where we were trying to understand mortality associated with major hurricanes among older adults living with dementia. And again, using claims data, that's not the only data I use. But again, this is another Medicare claims study where we looked at a population of disaster exposed Medicare beneficiaries with dementia, compared that to Medicare beneficiaries not exposed to disaster, but also who did have dementia. What we found was that hurricane exposure was associated with increased mortality after 2 of the 3 hurricanes. And this was hurricanes Irma, Harvey, and Florence. An important finding that we found was that mortality peaked around 3 to 6 months after hurricanes Irma and Harvey, which really made us again think about those enduring effects of the disaster on health. And perhaps among people with dementia who had to evacuate or experience that fairly substantial loss of routine or even loss of infrastructure in their community, how might that have affected their health trajectory in the longer term? In that, I'm thinking 3 to 6 months after exposure to this hurricane. And then another finding we found was that mortality risk was highest among our oldest old, which is we think about as 85 or older, and among those who are dually eligible, which is often used as a marker for poverty. So probably one of my greatest loves is in terms of research is qualitative research and getting into the community and talking with people who've been affected by disasters. So in these 2 studies after Hurricane Harvey, we interviewed home health care nurses who cared for older adults after Hurricane Harvey. And we wanted to understand, how to better support older adults through the lens of healthcare providers in the home, how to better support older adults to stay in their preferred living environment or to age in place, and also how we could better support the home care providers who are actually providing this care in the home. And we found some really interesting results, really kind of heartbreaking. We learned from these home health nurses about the challenges they faced in supporting their patients who, worked their whole lives to have a home, buy a home, fill it with the things and memories that were very important to them. As you can see in the top, their Elvis figurines, their elephants with their trunks up. And they talked about the devastation that they saw among their patients about losing their homes. And, the feeling of defeat, as one person mentioned, of, moving from the home that's, been all they've known for 40 years into, temporary housing or a one-bedroom apartment. What they also told us is that as they're trying to support their patients, they're also thinking about how did they reconcile with, the stress and the trauma that they're also experiencing. So what we found was a little bit of both in terms of mental health. How can we build better systems of supporting older adults in terms of coping with these events, but also how can we better support the healthcare providers who are, right there in there during the disaster, trying to support these populations. The last part of the talk, switching to the last part of the talk, I wanted to talk for a few minutes about research needs and highlight the NIH Climate Change and Health Initiative Strategic Framework. As I mentioned, I'm an NIH Climate Change and Health Scholar for this year. What that role means is I'm spending a year supporting the NIH to build research capacity and think about different ways we can better engage with climate change and health research at the NIH, and also to better support those scholars who are looking to do work in this area. I'm, as we've talked about, I'm a health services researcher. And so when I'm thinking about the NIH Climate Change and Health Initiative and all those spokes on the wheel you saw in the last slide, I'm thinking about how we can better use health services research to understand how we're delivering care during disasters, how we're financing preparedness measures, and of course, as I've talked about, how we're thinking about outcomes of healthcare. There's any number of ways that health services research can engage with climate change and health work. I've listed a few on here. This is almost like a wish list for me. You've heard me talk about some of the secondary data analysis I do and the qualitative research that I do, the advanced statistical modeling that I do, definitely with a team that supports me in that, and then areas of research that I think are really important to inform climate change and health research, like simulations, cost effectiveness research, and importantly, implementation science, which an important part of my program of research. It's work that I'm moving into. If you're an implementation scientist and want to talk more about this, I would really love to hear from you. This is a study we published a year ago in the Journal of the American Medical Directors Association that is focusing on ways we can better build healthcare readiness, which is that disaster management cycle I mentioned in nursing homes, which are known to have some of the worst health outcomes after disasters. So this work focused on how implementation science can be used to better bridge that know-do gap around what we know about you should be prepared versus how can we actually be prepared. And this paper highlighted some of those strategies where implementation science could really could help potentially build better outcomes. And that was, again, informed by my practice. This is a picture early in the COVID-19 pandemic where I was deployed to support the Maryland National Guard to conduct voluntary inspections of nursing homes around infection control, and also to teach nursing home staff around donning and doffing. So I highlight this picture partly because it's about nursing home preparedness and thinking about implementation science, and also to highlight what I talked about earlier about how the experience of a disaster can be highly disorienting for people living with dementia. And here in this picture, we have a bunch of Stay Puft Marshmallow people going into a nursing home that had been, were wearing this level of PPE because it was early in the pandemic. Nursing homes, if you may remember, were almost entirely closed to outside visitors. So we're wearing this highest level of of PPE. But I also, at the time we were going in, couldn't help but think about, how anxiety provoking that must be to the residents of the nursing homes that we visited. So back to that NIH Climate Change and Health Initiative. These are some of the urgent research needs that the NIH has outlined on their Climate Change and Health Initiative website. And I've pointed red arrows to work that I currently do, thinking about who is most at risk and how can healthcare systems prepare for challenges to providing what's termed as adequate care, but I like to think of as quality care. And then how can communities best adapt to a changing climate or be able to mitigate, prepare for, respond to, and recover from extreme weather events. So back to my organizing framework to talk about the last section of this talk, thinking about policy. This is a photo from the U.S. Department of Health and Human Services, their top management challenges from 2023. These are, you'll see the red arrow is pointing to their number one top management challenge, safeguarding public health, where they've highlighted strengthening emergency preparedness and response capabilities in our healthcare systems. So this, as I've said twice already, this is from 2023. I update this, I use this slide a lot. I've updated it the last 3 or 4 years because this was the same challenge in 2022, the same challenge in 2021, and if I remember right, the same top challenge in 2020. So definitely, an enormous policy concern about readying our healthcare facilities to be ready for extreme weather events and also pandemics. But are we really moving the needle forward on that? It's remained a top challenge for about the last 4 years, perhaps in part due to funding challenges. This is an infographic that came out in 2024, and it shows there's been a 34% decrease in public health preparedness funding for healthcare institutions since 2003. And we sort of consistently see, you can see the ups and downs here in this infographic. And that's something that, is the bane of a disaster researcher's existence, is that when there is a substantial, disaster that's in the media, we see funding and interest go up. And as soon as that disaster or pandemic leaves the media, then we see the funding dry up and go away. So, a point I make, perhaps you've heard before, is that we are continually reacting to disasters rather than being proactive. And, what we really need is systems like this to have sustained funding to better support getting that first part of readiness for a disaster in place, which is mitigation and preparedness, so that we can better respond to and recover from those extreme weather events, and in this case, also pandemics. So with that, I will say I often get asked, how can I be involved? How can I be involved? And what I always say is there is room for everyone, whether you're thinking about advocacy, research, or clinical practice. I highlight here a number of organizations that are, leading the climate change and health movement that either I'm involved with or have some knowledge of. Climate for Health, Physicians for Social Responsibility, Healthcare Without Harm, Global Green and Healthy Hospitals, and the Alliance of Nurses for Healthy Environments, who's actually hosting me here as an observer at COP29. So if you're interested in being involved in this organization, any of these, to my knowledge, all of them welcome membership and engagement without any membership fee or kind of obligation. And so I encourage you, if this is your, first foray into thinking about climate change and health, maybe to check out some of these organizations. So with that, I'll say thank you so much for the opportunity to be here and talk about some of this work today. And I'm definitely happy to answer any questions.
Thank you so much, Dr. Bell, for that wide-ranging and really, really insightful talk today, and sort of aptly centered in at the climate change conference that you're attending right now. So thanks for sharing all of those experiences. And so I welcome everyone to introduce questions into the Q&A, and we'll sort of ask them as they come up. And I'll take the prerogative perhaps to start with one. And one of the areas that I was interested in as you were talking is in your conceptual model, how sort of, individuals are obviously housed within interpersonal relationships and communities. But what seems pretty unique about the space that you're studying is that healthcare systems are also part of communities, and so that they are affected by disasters and sort of health events, both the people that are part of healthcare systems and the buildings, the infrastructure. They sort of lose power to the same extent, perhaps, that people around them do. So I'm curious just maybe to have you comment on what you've learned both in your research and sort of what you've seen personally about how, the healthcare system itself is affected, and then how that has sort of more downstream implications for the fact that, we're not separate from the people that we serve.
That's a really great question. And, as I've hopefully outlined a little bit in my research, I think a lot about that. It's the impact of infrastructure failure, rather than the shock of the disaster itself. We're inundated by rain, perhaps from a hurricane, but that rain causes loss of power, loss of transportation, your loss of ability to get to your healthcare treatments. Or in the case of being in Hurricane Maria, there was limited access to, grocery stores and fresh foods. And so big changes in nutrition from eating shelf-stable foods. So all those things, impact to put greater pressure on healthcare systems, which operate, kind of at capacity on a daily basis, much less when there's a shock, or much more, I should say, when there's a shock. So that kind of strain on healthcare systems that we see on a daily basis, which is magnified during a disaster, is, definitely, hopefully, those policy needs that I'm talking about come into play here, where we prioritize so many things, but prioritizing emergency preparedness has not been as great of a focus, and really needs its own kind of greater attention, research, greater understanding, so that we can better support, the healthcare institutions can better support communities and individuals they serve.
Great, thanks so much. And perhaps here another question here is, what do you think would be the number one most important thing for, a healthcare system, say like a large academic healthcare system in the Midwest, to focus on, for preparedness in our specific context?
I am going to answer that by giving a different example. So, I'm at University of Michigan, which actually has done a lot of work around emergency preparedness, has regular training drills, emergency management team that's working to build preparedness, and actually dealing with a smaller number of disasters that you might actually not hear about on a daily basis, like cyber attacks, for example. I don't know if you've experienced that in Madison, but in Ann Arbor, that's been fairly substantial for us. In 2017, the Centers for Medicare and Medicaid Services established the Emergency Preparedness Rule, which meant that any healthcare institutions participating in Medicare or Medicaid programs had to meet certain emergency preparedness requirements, like training, drilling, and having a written plan. So what that means for a fairly well-resourced setting like University of Michigan, or perhaps University of Wisconsin as well, is that, maybe we're doing a little bit better in terms of preparedness, but it's those institutions that are not as well-resourced, that don't have the capacity or the funding to do that required training, testing, having a well thought out and practiced plan, that is where we actually see, in terms of older adults, the most adverse outcomes, and that's nursing homes again, particularly is a big challenge. Um, so I wish I could say, what is one thing out of many. I'm not sure I can really answer that, but I guess what I would say to close this long-winded answer is that making emergency preparedness a part of your regular practice as a provider or as an institution, rather than just something you do once or twice a year to meet those CMS or Joint Commission requirements, but rather make that like what are those small incremental steps I can do on regularly to be ready for these unexpected events.
Great, thank you. And maybe sort of, and here another question on more of a personal note, but how would if anyone was interested in getting involved in the sort of disaster relief work that you practice clinically, what does that look like? And I think as clinicians, maybe we're not, some of us at least are not as familiar with sort of how one gets involved in that kind of system.
Sure. So I've been doing this about 15 years on a disaster medical assistance team, or a DMAT. It is actually a job that you apply for on the federal government jobs website. And so I have seen recently that there were positions open for different types of healthcare providers. In order to get on a team, one of the greatest challenges that you have to face is actually navigating the federal government job application system. Which, if you've managed that, then you have succeeded in your first battle and probably will be ready for a deployment. But there's some things to know that come along with that. Really, these teams are looking for a wide variety of people, not just trauma surgeons and nurses and emergency nurses. They need pediatricians. They need internal medicine, family practice, OBGYN, for example, are groups that I've deployed with. But what's important also about this position is that it's a paid position. So it falls under, it's called USERA, the Uniformed Services Employment and Reemployment Act, which is the same act that governs the National Guard. So basically, when I deploy, my employer cannot penalize me for deploying, and I can't be prevented from deploying. Definitely easier said than done when you have, you're on service the next week or something like that. But there's kind of structures in place to support healthcare providers who, are expected to have their regular job and become an intermittent federal employee when they deploy.
Great. And I think with that, we'll sort of reach the end of our time together today. So I just want to sort of thank everybody for joining us. And thank you again, Dr. Bell, for joining us from across the world to provide insights on your work and what you're learning in this really important space. So thanks again to everybody.
Thank you so much for having me. Good night.